Now I just have to remember how to present.
I just want to mention that we are recording this session today, so if you're not comfortable being on camera, you're welcome to turn it off. And Dr. Hoyt, you let us know if you prefer questions to be put in a chat or save them till the end of the presentation.
Awesome.
Thank you.
I prefer when we're as interactive as possible, especially with Zoom. So whenever you guys have a question, please just like interrupt me. Thank you so much, Olga, for inviting me to talk with y'all's group. When Olga told me about the food allergy nursing interest group, I was like, oh my gosh, this is awesome. And working towards having some sort of certification or specification of food allergy informed nurses, I just think it's amazing because food allergy itself is its own niche subspecialty, whatever you want to call it, of allergy and immunology, which is its own subspecialty. And so it's the benefit that nurses can bring to patient care. I'm just like the biggest champion for. So as Olga said, I'm Alice Hoyt. I'm a board certified allergist. I'm a fellow of the Academy, and I lead my own practice, the Hoyt Institute of Food Allergy. Let's see. Here's my disclaimer. All this is for educational purposes. And there's a lot of content in here. I'm not going to read everything verbatim, but we are recording this. So you guys can always go back to it, and you can always just email me or text me if you have a question. So by the end of this presentation, you're going to feel very confident in being able to discuss the following things. What is an IgE-mediated food allergy? What is OIT? How does OIT work? And who is a candidate for OIT? What are the risk benefits and alternatives to OIT? The logistics and safety guidelines of OIT, and is OIT right for your patient family? Before we get started, are there any like burning questions that people really want to make sure that I answer? Okay. If something pops up, please just interrupt me because I'm sitting here in a room just talking to a screen, and I much prefer to sit in a room of people talking to people faces, not just a screen. So please, okay. So what is IgE mediated food allergy? And I know some of y'all like this, you guys already know all this, but I felt like, let me just try to make sure everybody's all on the same page, and we'll go from there. I see there's something in the chat. Olga, would you mind managing that? And then if it's a question for me, just interrupt me.
Absolutely. The question we have from Jessica is, she's curious about the future role of biologics. So if you could touch on that.
That's a good one. When we get further into it, then we can talk some about that. I actually don't have anything about that in this presentation, but that is a wonderful question. So when we get a little bit more after defining it and what it is, then we'll talk about biologics and why they can be helpful in OIT. Okay, so first, let's really define food allergy, because when someone says I have a food allergy, that could mean like a bazillion things, right? So simply stated, a food allergy is an inappropriate immune response to a food. The cause is unclear, but basically the immune system thinks it's doing something good. It thinks it's attacking a bad guy. There's sort of three categories of food allergy. There's IgE mediated food allergy, meaning those IgE allergic antibodies that hang out on mast cells. I'll show pictures of that. There's non-IgE mediated food allergies, like food protein induced enterocolitis syndrome or FPIES. And then there's kind of like the mix, like IgE may be elevated in some of these disorders, but IgE really isn't the mechanism. And EOE, eosinophilic esophagitis, is one of those. So those are sort of the three categories of food allergy. So we can't talk about OIT and IgE without talking about mast cells. I studied mast cells in fellowship, and man, they are just the divas of food allergy and of allergy in general, right? Because they're the cells that are responsible for anaphylaxis. Every symptom that comes from anaphylaxis is because of these cells. So what is a mast cell? A mast cell, simply stated, it's an allergy cell, and when it releases its contents, then the allergic reaction occurs. Why? It's because of these little granules, these fuchsia things. They're fuchsia on purpose because they're like obnoxious and bright and they wreak a lot of havoc. So a granule is a component of a mast cell. Granules contain lots of different chemicals, histamine, vasodilators, basically all the things that cause the signs and symptoms of anaphylaxis are because these granules, the contents of these granules in particular, are being released by the cell. But how are they being released? Well, it has something to do with IgE. Yes, it does. So IgE, or immunoglobulin E, it's the allergic antibody, right? So whenever we get a flu shot, our bodies make IgG. Whenever we then see, our bodies then see the flu, then IgG binds the flu, and then it triggers our immune system to kill the flu, right? So IgE works differently. IgE pretty much stays on mast cells. There is some floating through the blood, right? Because we measure it in the blood. We can also measure it in the skin. I'll get to that. But it's on these mast cells, and mast cells live in your skin, in your mucous membranes, in your GI tract, basically anywhere that faces the outside world is where you have mast cells. And when an allergen binds to the IgE that hangs out on the mast cells, here's the IgE, it looks like a Y. Can y'all see my pointer? Okay, good. It looks like a Y. When it binds, then that's when the allergic reaction occurs. So this is what that looks like. Say somebody who has peanut allergy. This is somebody who has peanut allergy. This is their mast cell. These are their granules. And then this is IgE, specific to peanut. So you can have IgE to a bunch of different things, but if you're allergic to peanut, if you have an IgE-mediated food allergy to peanut, then you have peanut-specific IgE on your mast cells. That means that egg's not going to bind to this IgE. What's going to bind to the IgE is peanut. And so peanut protein binds to the IgE, and then that sends a signal into the cell that says degranulate. There's a bunch more stuff that happens, and I can think of multiple fellowship mentors who would be very fussy with my gross oversimplification of that. But you know what? That's what happens. And so if you're having an allergic reaction, it is because of these cells. Does anybody have any questions about this 40,000 foot view of mast cell immunology? Okay, I don't hear anything, so that's good. Okay, so let's talk about IgE-mediated food allergy. I want to make sure we have a very clear definition of what this is before we move on to a potential treatment for it. IgE-mediated food allergy is the most common type of food allergy. A kiddo will have IgE to the food, they can have them to more than one food, but they won't have enough immune tolerance to counteract that IgE. What I mean is you can have positive skin tests, positive blood tests to peanut and not be allergic to it. That's called being sensitized. When you're sensitized, that means that you have allergic testing to it, it's positive. But if you're tolerant to the food, that means you can eat the food despite that allergic testing, and you're not going to have an allergic reaction to it. So, and if you have an allergy, say you are allergic, that means you don't have enough immune tolerance to outweigh that allergy. And then when you ingest the allergen, then you can have anaphylaxis, hives, swelling, trouble breathing, vomiting, low blood pressure, altered mental status, potentially death. You can have all those symptoms because those granules and those mast cells contain the chemicals that cause all that. So they contain chemicals like histamine, that's very itchy, swelly, vasodilators, vessel getting bigger. That means your blood pressure is going to drop. That also means vessels getting leaky, swelling. Also, chemicals called bronchoconstrictors. So chemicals that cause your airways to tense down. So a lot of people think that, oh, well, people die of anaphylaxis because they get really swollen lips and basically like asphyxiate. But not necessarily. People die of anaphylaxis because they have significant bronchoconstriction, especially our asthmatics. And then also that vasodilation, that drop, that opening of blood vessels, drop in blood pressure, of course, it's going to increase our heart rate. That's what happens. That's physiology. But that drop in blood pressure ultimately If it gets too low and if it persists too long, then your heart is not going to be able to perfuse your brain anymore or your coronary arteries. So that is those are ways that people can have bad anaphylactic reactions. And again, it all comes back to those chemicals in those granules. Those granules are being released because the allergen is binding to that IgE. So it all comes back to IgE. So in somebody who has this, the way you actually diagnose it is really with a very detailed history, a targeted exam. You have to do a lot of exam if somebody's coming in to see you and they're not having anaphylaxis, right? You're reviewing the history. You can do skin and blood testing, skin prick testing, typically done on the arm or on the back. And what you're doing is you're dropping a little bit of the allergen right under the top surface of the skin, exposing it to those mast cells, so that if that person has that specific IgE to that allergen, it's going to cause localized mast cell degranulation. And then really an ingestion challenge is the gold standard to determine whether or not someone's allergic. So your treatment or your management options, I should say, are you can either avoid the food or you can pursue immunotherapy. Does anybody have any questions so far? Okay, I have this course on my site called What is Food Allergy? So you can look at all the different types of food allergies if you so choose. It's a free course. Go to hoytallergy.com and you can find it. Okay, what is OIT? How does OIT work? And who is a candidate for OIT? OIT stands for oral immunotherapy. It is a treatment for food allergy. It works by slowly teaching the immune system to tolerate a food. OIT helps the patient have a less severe or no reaction to the food. We never say that it's a cure. And the entire OIT procedure takes years and is divided into multiple phases. Before we start OIT with a family, we really talk about what the goals of OIT are for that family. So what do I mean by that? Well, before I get into that, I love timelines and I love maps. So I don't think we don't have a map in this, but we have a timeline in this. So what are the origins of food allergy in OIT? Limited reports of food allergy before the 1920s. And then we started seeing stuff in the 1920s to the 1970s that prompted more research into food allergy. In the 1990s, we noted the uptick in peanut allergy. That uptick in peanut allergy prompted experts to agree that introduction of potentially allergenic foods should be delayed. That was wrong. The thought behind this was that delaying the introduction of the food to little kiddos would give the immune system time to become ready for the food. Well, then what happened? We got even more increase in food allergy because later in the 2000s, we found that early introduction based on evidence is associated with decrease in food allergy because we can't expect the immune system to learn something if we don't teach it. And so introducing allergens early to the immune system, when I say early, I mean 4 to 6 months, depending on the kiddo, that teaches the immune system to tolerate the food. OIT was first reported in the literature in 2003. In 2013, egg allergy and severe eczema are reported as risk factors for peanut allergy. That's very important because that's how kids were risk stratified into the LEAP and LEAP-1 studies, which showed that early introduction of peanut in high-risk patients decreases the risk of developing peanut allergy, which was totally opposite than what we had previously preached. And then in 2017, we had the NIAID update for how to evaluate a kiddo at risk of peanut allergy. And then in 2020, Palforzia came on the market as an FDA-approved defatted peanut powder or peanut flour. But look, OIT was first reported back in 2003. And so since 2003 and before, allergists have been doing OIT well before Palforzia. Thousands of kids have gone through OIT well before Palforzia. So let's talk more about OIT. I mentioned earlier goals and how goals are super important when you're talking about OIT, because we don't say this is a cure, right? So OIT is not a cure for food allergy. OIT can increase a person's tolerance to a food, and increased tolerance then decreases the likelihood of a severe allergic reaction upon ingestion of the allergen. So why is this helpful? It's helpful because you have to worry less about a child accidentally eating what they're allergic to, because you know that they're not going to have a severe life-threatening allergic reaction. And that brings a lot of reassurance to families. So the two goals for OIT that I talk with families about are, is your goal for your kiddo to be bite proof, meaning if they accidentally ate a cookie with peanut butter in it, they're not going to have a reaction? Or is your goal for OIT for your kiddo to eat peanut butter and jelly sandwiches whenever he or she wants, and that's it? And that's what we define as free eating. And I'm talking a lot about peanut just as because, but we do peanut to, we do OIT to all types of foods. So I want to stop here for a second and go through the difference between bite proof and free eating, because they really aren't like medical terms. And so anytime you're using this terminology, you want to define it. So the definition of bite proof is being able to ingest a bite's worth of the allergen and not react. An example would be 1 peanut. And is this achievable with OIT? Yes, this is very commonly achievable. Free eating, the definition is able to eat as much of the allergen as he or she wants, whenever he or she wants. An example would be like, I want to eat 30 peanuts. And is this achievable with OIT? It is achievable, but it is less commonly achieved, especially as kiddos get older, the immune system gets more set in, then it's harder to grow that level of tolerance. Any questions about that?
Actually, you're
Okay.
saying that it's not, can I ask, because you did say at the
Yeah.
bottom, this is not a, the
Mhm.
definition may vary. Is this still, does the definition still vary between allergists, or is there consensus on that at this moment? Bite proof versus.
My understanding is that it can still vary. So I would just always check if an allergist is talking with you about being bite proof versus free eating, what exactly do they mean by that? And especially when it comes to OIT, because OIT has some things that are very streamlined, but because it's because we only have one FDA approved product for OIT, and because OIT has been going on for over a decade, there are multiple protocols and people do things different ways and consider things, sort of define things differently. So I always say, ask your allergist to define terms. So that's my answer, Olga. You know something different than I know.
No, thank you. I just wanted to double, and I know we
Okay.
have nurses on the call who work specifically in with oral immunotherapy, and maybe they have some input there, but.
Oh yeah, anybody else have any thoughts, comments?
I do have a question. You mentioned that, and this makes sense, that the older a kid gets, the harder it is to reach the level of being able to, free eat. And I'm sure that's a spectrum, but like, what age do you feel like that's just not really going to be a reasonable goal for a kid?
I guess I don't really put an age on it. I put more of a clinical case on it. So if, for example, if a kiddo is tolerating, like a 15-year-old is tolerating baked egg, but is still not tolerant of scrambled egg, then I feel like there's more hope for that child to be able to get to tolerating scrambled egg and be able to free eat, as opposed to a 15-year-old who is not even tolerating baked egg. I really specialize and do a lot of early immunotherapy. So, as soon as I'm diagnosing a baby with a peanut allergy and they have to have like legit history, I'm not quick to diagnose somebody, because I don't want to commit them to a diagnosis without being very firm and sure that, okay, they have this diagnosis. But as soon as they have the diagnosis, it could be 8 months of age, then we're starting OIT. And we just see such better outcomes with these younger kiddos because their immune system is still so plastic. So it's hard for me to put an age on it, but I will say that once we're getting into 6 to 10 years old, I'll tell you that age group, once they can start to recognize that something can really hurt them and they start sort of grappling with the concept of dying, right? This all goes back to developmental milestones too. It is hard to get them to consider doing OIT. And so then you're kind of stuck until they're teenagers and early teenagers. If they want to do it, then that's helpful. If mom wants to do it and kid does not want to do it, that's not going to work. But I really don't like to just put a blanket age on it. I will also say this though, it is very hard to start a kid on OIT towards the end of high school, and definitely like first years of college, because I'll show you the risk factors like stress, alcohol, decreased sleep, like all these things lower the threshold to have an allergic reaction. And so it makes OIT harder. So to answer your question, is there a specific age? I don't think there's a specific age, but the older you get, the more set in the immune system is.
Hey, and sorry, this is Jamie. So I do a lot of OIT. Sorry. And a lot of the older kids tend to hate the taste of like the tree nuts and the peanuts most often. So
Yes.
a lot of times for us, just to get them on that food to be bite safe is kind of key.
Hard.
So that they're safe for cross contamination, and then anything else is great. And then like milk and wheat and egg is a little bit different. A lot of, like for milk and egg, we'll try and do baked and all that stuff. But a lot of them hate the taste of tree nuts, and a lot of that is it's a struggle sometimes. It's they hate it, and we have lots of different sheets and options for them, and we try them, and it can be a struggle to get them on it.
Yep. Oh, Jamie, you're hitting the nail on the head there. And that's where I think SLIT, as it's becoming more available, is going to be helpful, because with SLIT, you in many cases can get to bite proof. SLIT is sublingual immunotherapy, drops under the tongue. You can't get as far with as you can with OIT. Like the studies have shown, like it's really hard, if at all possible, to get to free eating. But if you're just trying to get to like cross contact safe, then that's where I'm very hopeful that our SLIT studies will be very, very good and pan out like we think they will. Y'all are awesome. Okay,
I just had a quick
going. Yeah. Oh yeah.
Sorry. I'm
No,
sorry.
no.
Quick thing. My background is that a personal background with my kids is we did OIT starting like before the age of 2 with my twins. They were like 11 months for Peanut, and kind of like you said, we never actually, it was in the middle of COVID, so we never really truly confirmed the Peanut. It was just like they were definitely sensitized. They got kind of like face rash and neck rash, kind of where the Peanut touched them. But we never confirmed like, hey, if we don't let it get all over them, will they react? So they've responded extremely well. One went on to do cashew. Yeah. And like now they're like testing like 0 for Peanut, like 0 IgE, like no skin reaction. And so I know, so it kind of blurs the whole, like for us, like, not having that confirmatory oral test. It was like hard, it's like, well, are they like, were they ever, it's like hard to know. And so like you said, it's kind of almost like a commitment now. It'll always be kind of a fear in the back of my mind, but super grateful. And I'm super grateful to you for doing infant IT. I think I'm most interested in that, and like the, that it can be like disease modifying. And I'm really interested to hear more about, if you have the time, like about the future, what you think the future of infant OIT is going to be. And I just completely like any new parent, I'm just like, I'm a huge advocate for like early infant preschool OIT. We've just had such great responses with my kids. And but my question is like, I know infant OIT has not been embraced for that long, so you might not have an answer for this, but do kids tend to hang on to their tolerance? Like if they did start really young, when they hit like teenage age, are they still able to free eat if they're like kind of, at least consuming once a week or whatever? Is there enough data to know that yet?
I don't know if there's enough data to know that yet, because based on the OIT allergists who have at least 2 years ago at our like big OIT meeting, only like a third of us were doing early OIT, meaning as early as babies. And I think a lot of, and so that was only like 100 people basically were doing it. And so basically, like, if in the last 10 years more people have picked up on it, well, then we still don't have those kids out to teenage years yet. So that's where I'm really interested too, is to see where the data takes us, both for who ends up free eating. We do anecdotally see that, especially this younger group, they end up, some of them just kind of like go on. And I mean, I have a patient from back in 2017 and we started her very early, and now mom just kind of keeps it in the diet some, and she does great, like, so I think early OIT is where it's at, because it's basically, I consider it LEAP 2.0. Like once you diagnose somebody with the peanut allergy, then let's just go ahead and get it in their diet, because it's also, they just have less reactions as well. And slow and steady totally wins the race.
I love that.
I
That's
do
how
updosing.
I was just gonna say, I love how you said LEAP 2.0. Like that's basically how I interpret it. Like when I was stressing about whether to do it or not, that's basically like looking at the impact trial and like LEAP, and I just kind of put them together. And I was like, well, I hope this is the right decision. Like it seems like we have a real shot here, and it's worked out really well, thankfully.
That's awesome.
Yeah, so I love how
I'm
you
so
said
happy
that.
to hear that for y'all's family. That's awesome.
And I'm so happy. I love that you do on OIT. That's so great. So thank you.
I love it. I actually got a text from a patient who we did OIT with a few years ago, and is now doing 3 times per week, eats as much as he wants, make sure he eats it 3 times per week, still has an EpiPen. But she said of the 5 peanut allergy kiddos in his school district, 3 of them have gone through OIT and have like Epi at the school in case they need it, but are doing awesome. And it's like, I mean, it just makes everybody happier, because everybody feels better in those situations,
Yeah, it's so good to hear.
I actually wanted to mention, I think it was Dr. Wasserman who I listened to once and spoke with about, and I don't know if it's published or not, I should have asked them, when they took patients off for a month and to see whether they retained the immunity. I don't know, do you guys remember that? Was that published? I have to go back and look. And
the sustained unresponsiveness.
Sustained, exactly. And that was kind of interesting to see that majority did sustain, and the small minority, I think 20% did not, but they were able successfully to reintroduce the allergen again over time. So I thought it was kind of fascinating to see that it lasted for as long as 30 days. So that was interesting.
Yeah, and some studies do longer, but it goes down. And so let me fast forward. I'm sorry, Olga, were you going to say something?
Oh, no. And my other question for you was actually, because when you introduce it so early, and again, going back to that developmental stages, other than physical assessment that you see, what are some of the verbal cues that you pick up on? Because I would imagine at that age, when they're still have limited vocabulary, how do you pick up on some of the signs and symptoms other than physical ones? If there are potentially, reactions or things that don't go right with the process.
So reactions that we look for are a sudden change in the baby's demeanor, and moms and or dads are with the baby the whole time. And so we talk to them and we say very explicitly, like, if you feel like your baby is suddenly not acting himself or herself, let us know. So something as nuanced as that. Of course, puffiness, hives, but really like that can be the first sign. It's just that the baby went from being like very happy to playful to just kind of like very quiet. And that is a sign. That is a sign like, what's going on? So that's what I would say is the biggest one. And of course we say, we tailor it around nap time so that they're not coming in tired. We want them to come in and be ready to eat their dose. All those strategies, really working with families to make this the best possible experience for them. I want to fast forward.
Oh, I was just going to say, I know you want to move on. I just had one quick question. And this is because my personal history with my son, he wasn't diagnosed until he was 9. And he used to eat things with tree nuts in them, and whatever happened. But he's obviously not got as much of a plastic immune system as an 8-month-old. But does it also depend on how recent their initial reaction or diagnosis was to start OIT? Does that make any difference at all?
So what I would say to that, because that's a really interesting question, what I would say to that is that if a diagnosis, it's hard to give you an evidence-based answer because I don't know if we have the evidence for that, to be quite honest with you, because as an immunologist, I can definitely consider that once somebody has an allergy and their immune system has been used to making IgE specific to that food, that means cells have multiplied that make IgE specific to the food over and over and over and over and over. It's hard to think that if it's a new onset compared to it's been there for years, that the new onset wouldn't be easier to kind of kick back over. But I really have no evidence to tell you one way or the other. But that's a great question. I might kick that some of my colleagues.
Thank you.
So these are the goals. Y'all, this slide's been up for a while, so y'all probably read that. I do want to spend a little time on this. And Olga, can I have like 8 more minutes? Okay,
Yes,
thanks.
we've got an hour if you need to. We just need maybe 10 minutes to go over the agenda at the end. That's about it.
Okay, I'm gonna try to kick it into high gear. I shouldn't have had so much content, but I just thought it was all really important. I thought y'all would all be interested in it. So
Yeah.
This is how I define the OIT journey: escalation, buildup, maintenance, and then tolerance preservation. Escalation is when you give, like when you're starting OIT and you give these teeny tiny doses and you go up, maybe a little bit above what is going to be their go home dose. And then you go into the up dosing phase. I will be honest with you, I very rarely, if ever, do this escalation because my protocols start very low. And I don't like the idea of families having to come in for 5 or 6 hours into my office. I feel like that increases anxiety of like, oh my gosh, we're going to react to this dose, we're going to react to this dose. When we have so much data that by just starting low enough, you can just give 1 dose. And when we give that first dose, we do have them stay in office for 2 hours. And I'll talk about that, why 2 hours in a minute. But then all of our other up doses, it's a 1-hour observation in my office. Some people do a 30-minute observation. I really like 1 hour. I'm very conservative when it comes to OIT. I'm very proactive about it, but I'm very conservative about it. I do not like any fireworks. And part of not liking fireworks is why I updose every 2 weeks. Some allergists updose every 1 week, but I really attribute our excellent safety data to and not having reactions at home, because I don't want to put that on a parent, right? To really keeping kids on it for 2 weeks. And plus, I mean, a lot of them are toddlers. And so they're getting cold, they're getting like a fever, we're holding a dose here or there, or whatever. And so why rush it, right? This is a long process. So why rush it? Why have drama? Then they get up to what's called maintenance. And example for my peanut OIT protocol, maintenance is a 1/2 teaspoon of peanut butter. That's about 500 milligrams of peanut protein, which is almost 2 peanuts. Palforzia, which is the FDA approved product, is the maintenance dose is 300 milligrams. So I like us to get a little bit above that. And then they stay on that maintenance for anywhere from 1 to 3 years. Every year we repeat skin testing and especially blood testing. And what we're hoping to see is that their testing is going down. If it goes down low enough, or by 3 years, we'll do a full dose ingestion challenge. So that's about 2 tablespoons. So they were eating 1/2 teaspoon. And if they're eating 1/2 teaspoon, by the way, then they're bite proof because they're eating 1/2 teaspoon of peanut butter every day and they're not having a reaction to it. So then the challenge is 6 teaspoons or 2 tablespoons. And if they have a negative challenge here, then we go into what I call tolerance preservation. And that can be personalized based on allergen and patient of how much of the allergen do we need to keep in the diet in order to preserve the tolerance that we just worked very hard to achieve. And there's no magic answer. There's no algorithmic formula to know what exactly that amount is at this time.
Can I
For
ask a
peanut, we
question?
tried to do, yeah.
So are the kids on dosing up until that 2 tablespoon challenge?
They are on maintenance, half a teaspoon every day.
Okay, so do you do sustained unresponsiveness challenges after that?
I don't, because some patients, like when I lean a lot into the LEAP study, because I think the LEAP study was done very well. So they were on peanut from anywhere from 4 months up till 5 years, right? And then they said, okay, if you were eating peanut up until age 5, stop eating it now, and then reintroduce it at age 6. Most of those kids were not allergic, but some of them were. Some of them lost their tolerance. When you look at other sustained unresponsiveness studies, 1 month, 6 months, whatever the case is, some kids lose their tolerance. And I don't want the kids to lose their tolerance. I feel like I am not convinced for my clinical practice that there is significant benefit to doing the sustained unresponsiveness challenge, because it's not going to change the fact that the kid needs to keep what I call intentional ingestion of the allergen going for a specific period of time. For the peanut kids, I like it to go for a few years. For egg and milk, then they're getting it in their diets in other forms. So that's a little bit more, that's a little bit different approach. But that's why I don't do the sustained unresponsiveness challenge.
And when they keep it in the diet after passing the full dose challenge, do you still tell them to follow the same precautions, like not taking it when they're sick, things like that? Or is it just kind of like, just make sure you eat it a few times a week with no rules?
So that's a really good question. If the kid doesn't like it and it's really hard to get them to eat it, then we basically go back to doing maintenance dosing, like half a teaspoon. Maybe we'll cut it down to 5 days a week. And for those first like 6 months, then we're still having the safety parameters around it. And this is where it gets really nuanced, and different allergists do different things. Some people are going to keep those safety parameters there of no exercise 30 to 60 minutes before or 2 hours later. Some allergists are going to start to back down on that because the change that's happening after this negative ingestion challenge is that we're going down on the dosing. And we're doing that because we think the immune system can maintain the tolerance, but without so much intentional ingestion. So I still have them carry their EpiPens as well, their epinephrine auto-injectors as well, for at least that next year. And then we revisit their testing. We look at, have they had any accidental ingestions? I wish I had a more like firm answer on all of this. And I know a lot of my OIT colleagues do too. And that's where we're hopeful that a lot of the research will come in and help give us these answers to guide us on who needs to keep how much of the allergen in their diet for how long. And can they go play a football game after eating a peanut granola bar?
Gotcha.
Such good questions.
Hey, so this is Amy. So there are studies that, and there are studies, one of them, where part of the study was some of the kids were dosing only like once a week. Some of the kids were dosing twice a week. Other kids were dosing every day. So that study is like almost done and transitioning, is closing out soon, I believe. But so there are studies that do like show, like are looking at, do you need to be on dosing daily, or can you be a little bit more sporadic with dosing, and does it have to be, you know, as consistent?
Right. And it'll be so good when we have good data and we can really characterize individuals based on their specific risk factors, on their specific sort of immune profile, is what I like to call it. Yeah, and that's exciting about all of this, is that there is so much energy and research into it. And ultimately, what's so nice is that these kids are bite proof.
You know what, we need Chat GPT to help us get all this data into.
I love it.
Consolidated
Okay,
format.
I don't want to go too much over. You guys will have this. This is who is a candidate for OIT. So y'all can go back and read these. The risk, benefits, and alternatives. Clearly, these are the risks, highlighting that some kids get EOE, not many, but some do. These are the safety guidelines that we tell patients: don't dose on an empty stomach, don't dose as they have fever, all of these things. They're contacting me if any of these things are going on, and we're tailoring their plan based on what's going on with them. Because typically if they miss a dose, like if they just text you the next day and they're like, oh, we missed a dose, something happened outside their normal routine that they missed the dose. And so you want to know what's going on. The other benefits, it can reduce the risk of experiencing allergic reaction. Clearly, we talked about this. Alternatives, sublingual immunotherapy is becoming a bigger player. EPIT is still in development. That's a peanut patch. And then avoidance is still absolutely an acceptable plan. Like, no parent should feel bad if this isn't the right season for their kid to do OIT. Like, no, like this has to work for the family. It really does have to work for the entire family. Logistics and safety guidelines. So I'm not gonna go through all of this. You guys can look back and see, but basically my patients are very much in touch with me. That's how I have developed my practice, and that's how I like to practice OIT. Is it's a very engaged approach. These are safety expectations. So if they're missing a dose, then they're letting me know. They have their epi available. I can go back and read these. This is part of the OIT reaction management plan. So this is different than their anaphylaxis action plan. Anaphylaxis action plan at school, if they're going through OIT for peanut or whatever, they still have an anaphylaxis action plan that says, like, if they accidentally eat it and they start having hives and swelling and vomiting, you're giving epi, calling 911, going to the emergency room. For OIT, a little bit different. If they take their OIT dose and they have like a couple hives in their hand, then they can monitor and just let me know. If they're a happy hiver and they're monitoring, letting me know, they can give an antihistamine, but really that's only treating us. Because if the kid's hiving and is happy, like, it's fine, like, just let the hives naturally go away. But if they start vomiting, if they start having any airway involvement, you're giving epi, going to the emergency room, and then letting me know. I know there's a lot of discussion in our community right now about, can we say, okay, give 1 dose of epi and observe before saying calling 911, go to the emergency room. And so I am starting to have that conversation with some of my families, especially given some of the EMS challenges we're having down here in our community.
Can I ask about antihistamine? Because I know there's different preferences among physicians. I know you put Claritin here, but Zyzil and Zyrtec is what I hear is also pretty prevalent.
Yeah, it's those are very potent, and they have a little bit quicker onset of action, but they're also not technically definitely Zyrtec is not non-sedating. And so since I pay so much attention to a kid's mental status, then I don't want anything that's going to make them kind of groggy. And Allegra and Claritin are the ones that are non-sedating. And Claritin has pretty easy dosing, which is basically like 1 milligram for 1 year of age, up to 10 years. But typically, I really discourage my patients from even using an antihistamine, because for the most part, it really is like the kids just might have a few hives. And again, with our protocols, we're very slow and steady. And so very rarely am I getting any sort of calls. And it's not because these kids aren't allergic, because they're allergic. It's because we're just going slowly. And, if mom says, Dr. Hoyt, like, he just doesn't feel good. So, should we push back? Should we push back our up dose? Yes, we should push back our up dose. Like, if that's even like coming to your mind, then yeah, let's go ahead and push it back. But yeah, so that's my thought. I don't think it's wrong to do Zyzil or Zyrtec. This is just part of my art, y'all.
I have a quick question about that. So in some of the patients that I've treated who have also like allergic rhinitis, and you've already tried them on Claritin and it doesn't work at all for them, and you put them on, say, Allegra or Zyrtec, Would you take that in consideration that say Claritin doesn't work as well for them? I know that, anaphylaxis and hives is different than allergic rhinitis, but if it's kind of an individual factor that say Claritin doesn't work as well for that patient. I don't know if you've ever considered that, but I don't.
Yeah. So if a patient tells me that, I'm going to talk about two things. I'm talking about one, that the first line therapy for allergic rhinitis is a nasal steroid spray. I really like Flonase Sensimus, the one with the blue cap, because it's more of a puff, doesn't have a weird taste / smell. So kids are more likely to take it. But so I try to get them to doing a nose spray instead of doing the antihistamine. But if they do tell me that the antihistamine that works for them is such and such, then I'm like, okay, that's fine. Because you also have to have family buy-in, for lack of a better term. And this is not a mountain that I'm going to die on of which antihistamine you're going to take should your child have a few hives. Because ultimately, if they're having a severe reaction, they're going to do epi. So I think that's a totally fine way and a great way to really personalize the care plan for your patient.
Can I ask,
oh,
sorry, go ahead.
Go ahead, Laura.
I was just going to say, I know another symptom that, at least in our experience, has been more subjective and frustrating is we're baked egg tolerant, and actually, like, one of my twins is already doing scrambled egg, and our allergist really just gave us like free reign on like advancing the baked egg, and so I've been experimenting with scrambled egg. There's been like a couple times where my one that is clearly more allergic, one lost her skin prick test, the other hasn't yet. And so she will, with the cough, it's kind of like she'll eat egg and then maybe like 15 minutes later, like, I don't know, choke on a squeeze pack or something. And I don't know if she's choking but then coughing for like the next hour, doesn't have a history of asthma or anything, no wheeze. And it's just so like, oh, it's the worst when you're just so hyper vigilant, watching them after too, that it's kind of like, am I making a big deal out of like a little cough here and there? Or like, is this something really to tune into? So I don't know if I don't know if that's come up for you in your practice with patients, the coughing, subjectiveness, or if they're getting over like a viral infection,
Yes. So cough can be a funny one. That's something what I recommend is doing a cough diary, because I also wonder about reflux in that situation. And we know that there's that potential for eosinophilic esophagitis. I'm not saying that your kiddo has esophagitis.
It is a big fear of mine.
But the first thing to do, because I mean, you're hitting the nail on the head. Like, you're more vigilant when you're watching your kiddo to see are they going to have a reaction to this. And so keeping that log can be helpful, but then you also have to keep that log at other times too, and remember to like, oh, they're coughing now, let me write this down. And is this happening with other foods? Is this happening when they're laying down? Those types of questions. And egg is also just kind of a funny one. I hear that. I also hear a lot of kind of like the upset tummy, and those are just things where we, it's possible to kind of like step back some, but sometimes too, it's a phase. And so I say, let's continue to observe it and see what happens, because also we've also just grown all this tolerance to the food. So we don't want to just say, okay, well, let's just stop, because sometimes these things just play out, right? And sometimes it's just the body getting used to something that they have avoided for so long.
Right.
Dr. Hoyt, I have a question for you also. Yeah. So in situations, let's say if we're talking about milk allergy, but and again, if person wasn't introduced in the past and now being introduced, and we discover they also have lactose intolerance in addition to the actual allergy to the protein. So does that happen quite a bit or not? Because I haven't really seen that much of that. So I'm just curious if you've seen that.
That's a really good question. I haven't seen a whole lot of that, but I also haven't. I see a lot of kids who tolerate baked milk who, because allergists have been pretty good about getting baked things into the diet. It's just the other things that have not been great about getting into the diet. But if that's ever an issue, then we're going to see other symptoms like the bloating and the diarrhea. And so then we can and it's a little more delayed, right? And so then we could definitely start lactate, but at the same time, it's such a small dose when we're doing OIT to start with, that does give the gut time to start replacing that lactase enzyme. So it's not something that I see often, but I think it's a really good thing to consider if you are having a kiddo who's having kind of some of those funny tummy things that really aren't striking you as EOE, but striking you as something going on. And then you could try incorporating lactate when you're doing the dose, and that it's not affecting the protein, and it's the protein that's the allergen, right? Because the lactase deficiency is the lactase is breaking down lactose, the sugar. So it's two separate things.
Exactly. But also going back to EOE, so in situations where you suspect EOE, or if it's triggered by, let's say, OIT, is that an automatic disqualifier, or do you have exceptions with mild cases that you continue with the OIT regimen?
It used to be an automatic disqualifier, but now in the OIT allergist world, we're talking about stepping back on dosing, working with your GI doctor to find like a good regimen of your PPI to see if we can sort of calm all that down while not necessarily up dosing, but keeping some of the OIT present to continue that tolerance you've developed. And this is another area where I think, we haven't talked about biologics, but this is an area where biologics can be very helpful, because dupilumab they got approved recently, right, for EOE. So, so if you look at Palforzia, then they're going to say, you got to quit. But the OIT allergist community is hesitant to quit. And a lot of that is because once moms see a kiddo is eating the food to which like almost killed their child, it's hard to stop that. So
yeah, what I've read
a lot
is
of this is an art,
yeah, I think it's Dr. Wasserman who calls it an EOE-like syndrome. Are you familiar with that? Yes.
Yeah, ELORs. So, and it's all nuanced, and I was glad that a couple years ago, Dr. Wasserman had a great paper published in JACI, or was it JACI in Practice? It's I think it's called Private Practice, or I think it's called Private Practice OIT.
It is.
The name's
It
probably
is called
escaping me. Yeah, and it was really nice because for years there was a lot of this when it came to doing OIT. One group of allergists was very much, it should only be done in research. The other group of allergists like, well, we've been doing it for years and kids are doing great, so why are you withholding this from some kids? So really the allergist community is starting to come together now. And so hopefully we can work together and have more, really more studies and evidence to provide kids the best possible treatment and the families the best possible treatment. And that's how I started doing OIT. Was I went to the academy meeting and I was like, I can't just not do anything anymore. There's too much evidence saying that I can help these kiddos at least be able to tolerate some peanuts so that their moms aren't crying in my office that they're going to send their kid to school and their kid's going to die, So, but every allergist has to make that decision themselves. So I've gone way over my time. I want to highlight that avoidance is an absolutely acceptable management plan. OIT is not right for every family. It really has to be the right season. And now we've talked a lot about this. I know that some of you guys are like super experts on doing OIT with families, and some of you guys, it's more a newer thing for you. So I hope that you've enjoyed this presentation. I hope it's been helpful to you. Congratulations, all of us, for getting through my presentation. But please feel free to reach out to me if you have any more questions. I loved all your questions. Thank you so much for all of your comments and really sharing. And again, thank you so much for having me. I really appreciate the opportunity to talk with you guys. Y'all are awesome.